When you hear the words pelvic floor, what is like the very first thing that pops into your head?
Right. Usually it's,
I mean, if you are like almost everyone else, you probably think of weakness.
yeah,
You think of leaking a little urine when you sneeze, or that universal, almost cliche advice to just do your Kegels.
exactly.
We are constantly told we need to squeeze, to strengthen, to tighten up. But what happens when the exact opposite is true?
And that's where it gets complicated.
Right. Welcome to the deep dive. Today we are taking a massive stack of research, medical journals, physical therapy protocols, urology reports, and clinical guidelines on pelvic health.
It's a lot of material.
It really is. And our mission today is to explore a widespread, but honestly vastly misunderstood condition. We are diving into severe pelvic floor hypertonicity.
Otherwise known as an overactive pelvic floor.
Exactly. What actually happens to your body when these muscles are just too tight and they simply refuse to relax?
Well, it really requires a profound shift in how we normally think about the body. I mean, most of us imagine the pelvic floor as this rudimentary muscular sling.
Just kind of hang in there.
Right. But to truly grasp hypertonicity, we have to completely redefine that anatomy. It is a highly complex, dynamic hammock made up of layers of muscles, intricate nerve webs, and thick connective tissue sitting at the very base of your pelvis.
Wow. Okay.
And for that hammock to function properly, it needs to balance two states. The first is tonic activity.
Which is what exactly?
That's your constant supportive baseline tension. Basically keeps your organs from essentially falling out.
Oh, wow. Yeah, that's important.
Very. And the second is phasic activity, which refers to the reflexive, split-second contractions and relaxations needed for daily life.
Like jumping or coughing.
Exactly, or going to the bathroom. It has to be able to dynamically respond to everything you do, expanding and contracting on demand.
Okay, let's unpack this, because if that hammock gets wound too tight, it seems like it would completely compromise the structural integrity of your entire lower body.
It does.
We are moving from a hammock that gently sways and supports to one that is pulled so taut it starts pulling on the literal framework of the pelvis. How does a person end up stuck in that state of chronic contraction?
Well, in the clinical literature, this state is defined as an overactive pelvic floor, or OPF. It means the muscles simply do not relax when they are supposed to, or they actively contract when they should be resting.
So they're just stuck.
Yeah. The primary driver here is a phenomenon known as unnecessary muscle tension.
Unnecessary.
Right. It's muscle activity that is completely unintentional on the patient's part. You aren't actively trying to squeeze those muscles.
I see.
But interestingly, because it involves skeletal muscle, it is a tension that is amenable to voluntary control once a patient actually learns how to identify it.
I think the easiest way for you listening to visualize this unintentional tension is to think about TMJ, or chronic jaw clenching.
That is a perfect comparison.
Right, because when you are deeply stressed, you might unconsciously grind your teeth or clench your jaw while you sleep. It is an unconscious physical expression of anxiety or a mechanical compensation. But with hypertonicity, instead of clenching your jaw, you are literally clenching your pelvis.
What's fascinating here is how perfectly your jaw-clenching analogy illustrates the underlying neurology.
Oh, really?
Yeah, because the pelvis is wired through two major communication highways. You have the pudendal nerve, which commands the voluntary muscles and carries sensory information, and the hypogastric nerve, which regulates the autonomic involuntary functions like localized blood flow.
Got it.
So when you experience chronic stress, trauma, or pain, a specific reflex arc called the pudendal hypogastric reflex becomes completely dysregulated.
Wait, I want to pause there because I'm a little confused. I understand how, like, physical trauma, maybe a major pelvic surgery or a severe obstetric tear during childbirth, or even sitting with terrible posture that tucks your tailbone all day, mechanically shortens those muscles.
Sure, the physical mechanics make sense.
Yeah. But how does psychological stress translate to a locked-up pelvis?
Well, it comes down to the sympathetic nervous system, our fight or flight mode.
Right.
When that sympathetic drive is constantly activated by stress, the hypogastric nerve floods the pelvis with signals that restrict local blood flow and drastically crank up the resting muscle tone.
So it's preparing for danger?
Exactly. Your body essentially curls inward to protect its most vulnerable organs. You are unconsciously bracing for a physical impact that never actually comes.
Wow.
And over time, the nervous system just forgets how to turn that bracing mechanism off.
And because these specific muscles surround your most vital, sensitive organs, having a clenched jaw in your pelvis ruins basically every daily biological function you have.
Oh, absolutely.
Because those high tension muscles are wrapped right around the urethra and the bladder, which means an overactive pelvic floor acts as this master of disguise, right? It masquerades as other organ diseases.
It truly is the great mimic in the medical world. Let's look at urinary symptoms, for example.
Okay.
When the pelvic floor is hypertonic, it actively compresses a tiny muscle called the compressor urethrae, and it clamps down directly on that pudendal nerve we mentioned earlier,
Ouch.
right? And when a sensory nerve is squeezed, like a kinked garden hose, it fires off panic signals.
I can imagine.
For the patient, this translates into burning, neuropathic pain, an intense, relentless urgency to urinate, and constantly running to the bathroom.
Which are the exact textbook symptoms of a urinary tract infection.
Exactly.
And this is where I really have to push back on standard medical treatments. If a patient comes into a clinic in absolute agony reporting burning urine and their urine culture comes back showing zero bacteria.
Yeah, it happens all the time.
Why do they keep getting prescribed round after round of antibiotics? I mean, the test proves there is an infection, right?
It is an incredibly frustrating cycle for patients, and it ultimately comes down to a gap in diagnostic training.
Really? Just training.
Yeah, many clinicians simply lack the specialized orthopedic training to look for musculoskeletal causes when a patient presents with visceral, organ-based symptoms.
That makes sense, sadly.
When a patient says, "My bladder hurts," the doctor looks exclusively at the bladder. They aren't looking at the muscular hammock supporting it.
So they're missing the root cause.
Right. What they miss are the myofascial trigger points, essentially deep, painful knots in the pelvic floor muscles.
Oh, like muscle knots in your back.
Exactly.
Mm.
These trigger points refer pain in a way that perfectly mimics the burning of bacterial cystitis. But there is no bacteria to fight. It is just a muscle in severe, localized spasm.
It seems wild that a muscle knot can trick a doctor into treating an organ.
It really is.
And from what I gathered in the sources, this mimicry doesn't stop at the bladder. The bowel dysfunction caused by this tension sounds just as extreme.
Oh, it's debilitating.
Right, because normally when you have a bowel movement, everything needs to relax. I read about a muscle that specifically has to get out of the way.
You're referring to the puborectalis muscle?
Yes, that's the one.
In a healthy pelvic floor, when you sit down to pass stool, the puborectalis has to physically lengthen, and the entire perineal body must drop to open the anal canal.
Okay.
But with severe hypertonicity, we see a mechanical failure known as a paradoxical contraction.
Meaning the body does the exact opposite of what it should.
Precisely. Instead of the perineal body lengthening and softening to open the canal, it shortens, lifts, and violently contracts.
Oh, man.
Yeah, the patient is essentially trying to push matter out against a heavy, tightly bolted door.
That sounds awful.
It is. This mechanical blockage leads to severe chronic constipation. It also physically alters the shape of the stool as it forces its way past the tension.
Because it's being squeezed so hard.
Right. On the clinical Bristol stool chart, this presents as types 1 or 2, either very hard pebble-like stool or incredibly thin ribbon-like stool, because the muscular opening is just so restricted.
And even if they manage to get past that bolted door, the aftermath sounds agonizing. People with this condition often experience intense, cramping pain deep in the rectum after they finally manage to have a bowel movement.
Yes, the post-bowel movement pain is a huge indicator.
But why would the pain spike after the task is done?
Well, that phenomena is driven by the internal anal sphincter. Under normal circumstances, once stool passes, this sphincter reflexively closes to maintain continence.
Sure.
But in a hypertonic pelvis, the baseline tension is already pushed to the absolute limit. When the sphincter closes, it doesn't just return to a resting state, it overcloses and snaps back into a severe tetanic spasm.
Like a Charlie horse.
Exactly like that. The physical act of defecation pushes an already exhausted muscle over the edge into a cramping state that can last for hours, sometimes even radiating down the back of the legs.
Wow. So solitary bathroom habits are turned into a daily nightmare.
Please.
But it's not just about what happens behind closed doors in the bathroom. When your pelvic muscles are completely locked up, it deeply, deeply affects human connection.
Yes, it destroys intimacy.
Right. This tension actively blocks and penalizes sexual arousal and intercourse across all anatomies.
And the suffering in this area is profound because it touches on such a vulnerable part of the human experience.
Definitely.
In women, this hypertonicity manifests primarily as dyspareunia, which is the clinical term for painful intercourse.
Okay.
It also causes vaginismus, where the pelvic floor muscles undergo an involuntary protective spasm that makes any penetration physically impossible. And then there's vulvodynia, which is a chronic, unexplained burning pain at the vaginal opening.
That sounds so painful.
It is. If you think about the physics involved, attempting penetration against unyielding high-tone muscles creates intense physical friction. This isn't just a vague discomfort. It causes actual microtrauma to the mucosal tissues, resulting in a severe tearing or burning sensation.
The mechanics of that make total sense. But for men, the presentation is entirely different, isn't it?
Yes, very different.
The muscles become so tight they actually restrict the blood flow required for an erection in the first place. I think this is known clinically as hard flaccid syndrome, or HFS.
That's right. The sympathetic nervous system is in such overdrive that the pelvic floor acts like a tourniquet.
A tourniquet, wow.
Yeah, the penis appears pale and semi-flaccid, leading to severe erectile dysfunction, loss of sensation, and extremely painful ejaculation because the muscles are just choking off the vascular supply.
And beyond the mechanics of arousal, both men and women with extreme muscle tension often report a very specific, highly distressing clinical symptom, right? Something called allotriesthesia.
Yes, allotriesthesia.
That is the sensation of having a foreign body stuck inside you.
Yes, it's very common. In clinical intakes, patients will frequently describe feeling as though they have a golf ball, a tennis ball, or even a heavy rock stuck inside their vagina, their perineum, or their rectum.
But obviously there's nothing there.
Naturally, there is no actual object there. What their nervous system is registering is the sheer density of their own hypercontracted pelvic floor muscles.
Wow.
The tissue has become so hard and fibrotic that the brain interprets it as a foreign object that needs to be expelled.
Which feeds right into this devastating psychological feedback loop.
Exactly.
You experience pain during intimacy, which creates intense anxiety and anticipation of pain before the next attempt at intimacy.
Right, you brace for it.
And that anxiety causes your nervous system to increase the muscle tension even further to protect you. And that increased tension guarantees even worse pain the next time. It's just a vicious cycle.
It really is a trap.
But here's where it gets really interesting. I was looking at the research on this, and there is a condition associated with this tension called persistent sexual arousal or restless genital syndrome.
Yes, PGAD.
I have to admit, I completely tripped over this concept. How on earth could a pelvic floor that is locked tight, cutting off blood flow and causing extreme pain, possibly result in a feeling of constant arousal?
I know, it sounds bizarre.
And an arousal that can't even be relieved by a climax.
Right, it sounds completely counterintuitive on the surface, but it all comes back to neurological misfiring. We have to go back to the pudendal nerve, which is being crushed by all those tight muscles.
Okay, the garden hose again.
Exactly. When a sensory nerve is squeezed that tightly for months or years, it starts to degenerate and panic. It begins sending a constant, unprovoked barrage of erroneous sensory static up the spinal cord to the brain.
Static.
Yeah. Now, the brain receives these intense, localized electrical signals from the genitals, but it doesn't know how to interpret them because they completely lack context.
So the brain essentially gets confused by the static.
Exactly. The brain misinterprets the static, blurring the neurological line between pain, pressure, and arousal.
Wow.
The patient feels a constant, intrusive, and often painful physical sensation of being on the edge of a climax.
That sounds like torture.
It is. But because the sensation is being artificially generated by nerve entrapment down on the pelvis, and not by actual sexual desire or dopamine pathways in the brain, achieving a climax provides zero relief.
Because the nerve is still trapped.
Right. The nerve is still trapped, so the static continues immediately.
It sounds absolutely exhausting. You can't just ignore a blaring signal like that.
No, you can't.
And from what I understand, this constant barrage of sensory static doesn't just stay localized in the pelvis. If you leave it untreated long enough, those pain signals travel up and literally rewire the brain itself.
If we connect this to the bigger picture, this brings us to perhaps the most critical concept in modern chronic pain management.
Okay, what is it?
Central sensitization. When your body is subjected to chronic inflammation or unyielding pain over a long period, the central nervous system actually undergoes a structural and chemical change.
A structural change.
Yeah. The threshold for your nociceptors, which are your body's specialized pain receptors, is drastically lowered.
It's like a car alarm.
Oh, that's a good way to put it.
Yeah, like if someone breaks a window, the alarm should go off. That's normal pain protecting you. But with central sensitization, it's like the car alarm gets so hypersensitive over time that it starts going off when a gentle breeze blows by or when a leaf hits the windshield.
That car alarm analogy perfectly describes what happens to the central nervous system. It becomes highly dysregulated and loses its ability to filter out non-threatening information.
Yeah.
Clinically, this manifests in two distinct ways. The first is hyperalgesia, which is a wildly exaggerated, amplified response to a mildly painful stimulus.
Okay.
And the second is allodynia, which is feeling severe pain from things that absolutely shouldn't hurt at all.
Like what?
Like the light touch of wearing tight underwear, sitting down in a soft chair, or even just the normal filling of the bladder. The brain's alarm system amplifies these benign inputs into screaming pain signals long after the initial physical trigger, like an old urinary tract infection or a childbirth injury has completely healed.
So the physical tissue down in the pelvis might be totally healed, but the neurological alarm in the brain is still screaming.
Exactly.
And that psychological toll has to be immense.
Yeah.
The clinical profiles of these patients describe deep, persistent feelings of helplessness and hopelessness.
Yes, the depression rates are very high.
And it makes perfect sense. The symptoms are completely isolating. They're invisible to friends and family on good days. But worse, they are deeply tied to functions that society tells us are embarrassing or taboo. You know, using the bathroom, having sex, dealing with their genitals.
Right, nobody wants to talk about it.
It forces people to suffer in silence and withdraw from the world entirely.
It is a profoundly heavy burden. Patients often feel like their body has completely betrayed them.
I can't even imagine.
But it is vital for anyone listening to know that while the nervous system can learn this hypervigilant pain state, neuroplasticity works in both directions.
Wait, really?
Yeah, the nervous system can also unlearn it.
Which leads us to the ultimate question. If the pelvic muscles are locked like a vice and the brain's alarm system is fundamentally broken, how do we actually fix this?
It takes a lot of work.
I'm sure. And I want to start by addressing the elephant in the room. If someone's pelvic floor is acting up, the first thing any magazine or generic health blog will tell them is to just do Kegels.
Yes.
Why are Kegels the absolute enemy for this condition?
Doing Kegels when you have an overactive pelvic floor is like taking a tight knot in a shoelace and pulling the ends as hard as you can.
Oh, that's a great visual.
A Kegel is a strengthening exercise.
Yeah.
It is a concentric contraction. But with OPF, you are dealing with a muscle that is already exhausted from being in a state of constant maximal contraction 204/7.
Right.
It cannot contract any further, and trying to force it to will only cause more pain and nerve compression. The entire goal of treatment for hypertonicity is not strengthening. It is relaxation, lengthening, and down training.
I'm still a little thing up on this, though. If we just need the muscle to lengthen and relax, why can't we just stretch it out?
What do you mean?
Like, if I have a tight calf muscle, I do a runner stretch and massage it, and I'm good to go. Why does treating the pelvic floor require all this talk about nervous system regulation?
Because of that sympathetic lock we discussed earlier.
The fight or flight thing.
Exactly. You cannot permanently stretch a muscle if the brain is constantly sending an electrical signal telling it to brace for impact.
Oh, I get it. The brain will just tighten it right back up.
Right. The physical therapy protocols have to trick the nervous system into letting its guard down.
How do they do that?
They focus heavily on things like diaphragmatic breathing. When you take a deep, proper breath into your belly, your diaphragm expands downward.
Okay.
Because the diaphragm and the pelvic floor move in tandem, that deep breath mechanically forces the pelvic hammock to drop and stretch from the inside out, while simultaneously sending a signal to the vagus nerve that you are safe.
That's amazing.
It really is. Physical therapists also use specialized internal myofascial release, manually releasing those trigger points and utilizing tools like dilators to help the tissue slowly stretch and accommodate pressure without the nervous system panicking.
And beyond the physical therapy, the clinical guidelines highlight advanced neuromodulation techniques too. One that stood out was dry needling.
Yes, dry needling is very effective.
And just to be clear for you listening, this isn't acupuncture, and it isn't just about taking a needle and poking a tight muscle to make it twitch.
No, it's very precise.
The research explains that when utilized by an expert, dry needling targets specific spinal segmental reflex arcs, specifically the S2 to S4 pathways in the spine.
Exactly.
By inserting the needle into the precise trigger point, you chemically and electrically interrupt the pain spasm cycle right at the level of the spinal cord.
Right. It forces a local twitch response.
And that exhausts the muscle, resetting the neurological tone and actively reducing the neuroinflammation that's driving the whole process.
It is a remarkable intervention when performed correctly because it addresses both the local muscle knot and the central nervous system loop simultaneously.
That's incredible.
Healing an overactive pelvic floor requires the patient to consciously unlearn their deeply ingrained holding patterns. It's a process of restoring embodied safety.
Restoring embodied safety. I love that phrasing.
Yeah, you have to literally teach the autonomic nervous system that the threat is past and that it is finally allowed to let go.
So what does this all mean? It means that treating severe pelvic floor hypertonicity is never a quick fix, and it's certainly not solved by just squeezing harder.
Definitely not.
It requires a highly trauma-informed multidisciplinary approach. You are looking at physical rehab to lengthen the muscle fibers, nervous system regulation to fix the broken car alarm in the brain, and often mental health care to process the profound isolation, all rolled into one cohesive plan.
Yes, it takes a team.
The pelvic floor truly is a miraculous complex structure. It holds our most vital functions together, our digestion, our elimination, our intimacy. But when it gets overworked and wound too tight, it requires immense patience, specialized care, and a completely different, much gentler understanding of your own body to heal.
Absolutely. And, there's one final, truly profound connection from the medical literature that I want to leave you with, which perfectly encapsulates how central this hammock is to our overall existence.
Oh, what is it?
Well, we've talked extensively about how deeply the pelvic floor is wired into the autonomic nervous system.
Right.
Well, in clinical observations, it has been demonstrated that physical manipulation and stimulation of the pelvic floor can directly affect a person's heart rhythm.
Wait, really?
Yes, this occurs through the activation of the vagus nerve, which runs from the brainstem all the way down to the pelvic organs.
The tension in the muscles at the very bottom of the pelvis can actually change the beating of the heart in your chest.
Yes, the neurological pathways are that intrinsically linked, which raises a fascinating question to ponder.
Right.
If our pelvic muscles are so deeply, fundamentally wired into our core autonomic nervous system that their state of tension can literally change the rhythm of our heart,
Yeah.
could treating chronic pelvic floor tension be the missing key to unlocking full-body neurological healing?
That is an amazing thought to leave on. Maybe the secret to relaxing an anxious mind and a racing heart actually starts by unclenching that hidden jaw in the pelvis. Thank you so much for joining us on this deep dive. If these symptoms sound all too familiar to you, please listen to your body and seek out the right specialized experts. You don't have to live with the alarm going off forever.